Good morning, everybody. My name is Dr. Brandon Dsouza. I'm a medical student from India. I grew up in Dubai and did my medical school at Dr. D.Y. Patil Medical Hospital, College and Research Center in Pune, India. Today at AMIQT, I will be talking about disorders of perception. So the first thing that you see right now is the mini mental state examination. During my rotation here at AMIQT, I performed the mini mental state examination for almost every patient. And it is quite an interesting test. It tells you about how the patient is, the mood of the patient, what are his thoughts, what is he thinking about, and most importantly, what exactly is he perceiving? Now, you might be wondering why I chose the topic of disorders of perception. Personally, I believe perception is one of the most important things because the universe does not exist unless we perceive it. And hence, this is one of the reasons why I've chosen this topic. So perceptions can be classified into, like the disorders can be classified into sensory distortions and sensory deceptions. In distortions, there is a constant real perceptual object which is perceived in a distorted way, while in sensory deceptions, a new perception occurs that may or may not be in response to an external stimulus. Now, I put this slide over here because it's really important, because a lot of people keep on using the word hallucinations, which sometimes can be a misnomer because what they actually are perceiving is a sensory distortion rather than a deception. If you can see on the right side, I placed a painting by a very famous artist known as Alex Gray, who specializes in, psychedelic art and altered states of consciousness and what people experience when they are on hallucinogens. Now, I'd like to talk about sensory distortions. So sensory distortions could be classified based on changes in intensity, changes in quality, changes in spatial form, or distortions of the experience of time. So if you look on the left side of my slide, you could see a man placing his contact lens, but as he's looking into the mirror, the image around him is very distorted. So this could be considered as a change in quality or a change in intensity. So I'd like to talk a little bit about changes in intensity. It could be either hyperesthesia or hypoesthesia. Now, what does that mean exactly? Increased intensity of sensations, also known as hyperesthesia, may be the result of intense emotions or a lowering of the physiological threshold. So what that means exactly is when we perceive anything in the world, there's a threshold to perceive it, to receive the stimulus. For some reason, whether it is psychological, psychiatrical, or even neurological, the threshold could be either lowered or increased. If there is a lower threshold, the patient will most likely experience increased sensations. Anxiety, depressive disorders, as well as hangovers from alcohol and migraines are all associated with increased sensitivity to sound, known as hyperacusis. In my rotation, I've asked many patients who had migraines, what are the things that they're usually sensitive to? And it could be smell, it could be sound, it could even be light, manifesting as hyperacusis, photophobia, and so on. So what happens exactly is the sensory threshold, once again, is reduced and they experience a heightened form of the sensation manifesting as pain and even sometimes developing into neurosis and anxiety about the condition. Other ways in which the sensory threshold is lowered down could be through the use of psychedelic substances, such as LSD, where patients might say, or people who use substances like this might say that colors are moving, walls are breathing, when in actuality, all that is changed is the threshold for the stimulus. Now let's talk about what happens when there's an increase in threshold for stimulus. Such a thing would lead to hypoesthesia, or such as hypoacusis, which is the features of disorders such as patients having depression or patients having attention deficit disorder. These patients would require a higher threshold of stimulus to feel something again. And for example, a lot of patients who suffer from depression, post-traumatic stress disorder, might not be able to taste food again. They might say that, oh, I'm not able to enjoy my favorite chocolate, or I cannot enjoy this glass of orange juice. The same thing would go for sound. They're not able to appreciate music the same way. Whatever things they don't like again because the threshold for stimulus has increased. Now let's talk about changes in spatial form. If you look on the right side of the slide, you can see two pictures. The top picture is showing a very familiar story when we were young, Alice in Wonderland, and you can see that she's already had the cup of tea and increase in size. The room is much smaller. This is known as changes in spatial form, also known as dysmegalopsia. Many conditions are there, such as Alice in Wonderland syndrome, and it was well known that Lewis Carroll himself suffered from migraines, and the migraines with aura would lead to changes in shapes of the room. The room would appear very big or very small, and called successively known as micropsia and macropsia. And this was quite an influence for his story of Alice in Wonderland. The final distortion of the experience of time I would like to talk about is perception of time. If you look on the bottom side of the bottom of the slide, you can see the famous Dali's clock. It's melting, like as he would put it, as a slice of brie in the sun. What does this mean exactly? So we perceive time in one particular way, but if we are depressed or if we are manic, time could be either fast or slow. As Einstein would say, time is relative. Now let's talk about sensory deceptions. I would like to talk more about this type of sensory condition. So we'll talk about illusions first. In illusions, stimuli from a perceived object are combined with a mental image to produce a false perception. Now, this is very important because I'll be moving towards hallucinations in a few minutes. And I would like to distinguish between illusions and hallucinations because they're two very separate things. So, as described by Sims in 2003, illusions can be classified into completion illusions, affect illusions, or pareidolia. Now, I'm not talking about illusions where you look at two lines and see one line is bigger than the other. I'm not talking about those. I'm talking about illusions which are related to the psyche. So let's talk about completion illusions. So completion illusions depend on the inattention, such as misreading words in newspapers. Like the other day, I was reading some words, and maybe you read the word "oh, okay," and your mental heuristic gives you the word books, but actually the word was something else. For example, like misprints in newspapers, or just basically misreading things. Affect illusions are a little different because they depend on the particular mood state. So, for example, a patient who has lost someone or a bereaved person might momentarily believe that they see the deceased person or the delirious person in a perplexed and bewildered state and may perceive innocent gestures of others as threatening. So this is another example of a sensory deception. But let's talk about pareidolia. Pareidolia is quite different from the other types of illusions because it's very interesting. It's a state in which vivid illusions occur without the patient making any effort. These illusions are the result of excessive fantasy thinking and a vivid visual imagery. They cannot therefore be explained as the result of affect or mindset, so that they differ from the ordinary illusion. On the right side of the slide, I put a picture of the Rorschach test, quite popularly used in psychiatry to assess the state of the unconscious mind of the individual. It's a form of directed pareidolia. But indirect pareidolia, an example I like to give you is this picture. So a few years ago on the moon, on the dark side of the moon, a picture taken by the satellite on the left side showed what appeared to be like a face. In actuality, when they looked at the picture from another angle, you can see that there is no face. So it is just the way we perceive it, and it is our fantasy thinking, the mental heuristics that give us the example of a face. Another example of pareidolia would be clouds in the sky. Ever sat down in the park and looked up in the sky and thought you see dogs or you see dolphins or anything as such? That is another example of pareidolia. Now let's move on to my other favorite type of sensory deceptions, which is known as hallucinations. What are hallucinations? Hallucinations is a false perception, which is not a sensory distortion or a misinterpretation, but which occurs at the same time as real perceptions. This definition was given by Carl Jaspers, a very famous psychiatrist and neurologist. And I would like to talk more about hallucinations because I want to distinguish it from illusions as well as sensory distortions. So what distinguishes hallucinations from true perceptions is that they come from within, although the subject reacts to them as if they were true perceptions coming from without. Now let's talk about this sentence a little more. So in reality, we perceive reality in one particular way. But what happens in hallucinations is that we perceive reality from the outside. At the same time, we are also perceiving something going on from the inside. So we are not able to understand that what exactly is going on in reality. And many times patients lack insight. And the more insight they lose, the more harder they fall into the delusions, and this can manifest into neurosis and as well as psychosis. Now, what is a pseudo hallucination? So before we go into objective hallucination and subjective hallucination, I would like to talk about mental imagery. Let's do a thought experiment. I'd like for you to imagine that you're in the Bahamas. Just close your eyes right now. You have a picture right there, right now. There's something going on in the back of your head. But when you open your eyes, you're not actually there. It's being perceived somewhere at the back of your head. This is known as a mental image or also a pseudo hallucination. I like to think of it this way. Imagine you're in the cinema and the guy behind you has the projector. The slide on the projector is the pseudo hallucination, and that is in the subjective space of the individual. But when this gets projected onto the screen in front of you into the objective space, that is known as a hallucination. So what are the causes of hallucinations? Well, there are many causes. It could range from emotion, suggestion, disorders of a peripheral sense organ, sensory deprivation, or disorders of the central nervous system. So let's talk about emotion first. Very depressed patients with delusions of guilt may hear voices reproaching them. I've met many patients who have been through traumatic experiences, such as abuse, and they have manifested their psyche into various hallucinations. And sometimes these voices could be very threatening. They could tell them to kill themselves, or they're a rotter, or that they stink, or many other things that could make the patients even worse. So this happens in depression as well as physical abuse. Another example is suggestion. If you look back in history, there was a very famous mass hallucination which happened in Fatima, Portugal, where a lot of patients, a lot of people, a lot of devotees of Mother Mary, they went to Fatima and they stared at the sun, and all of them were suggested, they were very suggestible at that moment, and they thought that the sun was dancing. This is an example of a mass hallucination, and it was a result of suggestion with the help of priests and a group in whom suggestion was believed to be relevant with a genesis of hallucinations. The diagnosis is known as hysterical psychosis. This shows that people can be very suggestible, especially in altered states of consciousness, and can be persuaded to hallucinate. The next thing I'd like to talk about is disorders of a peripheral sense organ. For example, let's talk about eyesight. Many patients, as they grow older and they lose their eyesight, may develop an interesting hallucination related to something known as Charles Bonnet syndrome, where the hallucinations develop as a result of a loss of vision, usually seen in patients with cataract or glaucoma, and patients usually have preserved insight. Another nice manifestation of Charles Bonnet syndrome could also be auditory. A lot of patients who have hearing loss or have sensory neural hearing loss, they also develop a form of auditory hallucinations, and that could lead them to have paranoia as well. That's why when we see a lot of deaf patients in the clinics, usually they're very paranoid because the body likes to keep a balance. If something is low, it will increase something else and create a form of neurosis, which could eventually develop into psychosis. Let's talk about sensory deprivation. So it's become very popular nowadays. A lot of people are able to induce hallucinations into their own minds by causing a state of sensory deprivation. In this picture, you can see a man floating in a tank, and he's surrounded by salt water. So what it does is when he closes his eyes and he closes the tank, he's in another world. He's not able to feel where he is. He's not able to accurately perceive where he is in the spatial surrounding. And as a result, it could lead to something known as perceptual disturbances. And let's take this one step further with something known as the ganzfeld effect. So what this effect is, what psychiatrists and neurologists did was they would take a patient into a dark room and they would deprive him of sensation. They would cover his eyes with a ping pong ball and play a static. So the patient is not able to realize what kind of perception he's having. And the body is actually addicted to perception. And if it's not able to perceive something accurately, you can bet that it's going to create something. And a lot of patients, when they experience the Ganzfeld effect, they experience like hallucinations and vivid imagery, which could be even similar to people suffering from psychosis. Now, what are the pathological or pathophysiological mechanisms involved in hallucinations? So in medical school, we've all learned that psychotic disorders most likely are a result of imbalances in the neurotransmitters, such as the dopamine pathways. And this is the reason why we administer antipsychotic medication, which affects the dopamine levels in individuals, especially in acute states of psychosis. A lot of time in the past, Haldol was given, haloperidol, which would help the patient come back to reality. So in schizophrenia and other disorders, you can see that overactivity of the mesolimbic pathway could lead to positive symptoms, and activity of the mesocortical pathway dysfunction could lead to negative and cognitive symptoms. So our understanding is that it's usually because of dopamine, an imbalance in dopamine, like an excessive amount of dopamine, which could lead to delusions and psychosis and perceptual imbalances. In psychiatry and neurology, anything related to perception has been as a result of imbalances in neurotransmitters. On the right side, you can see a study, and from the study, the basic summary is that schizophrenia probably involves multiple neurotransmitter system abnormalities. We know that glutamate and dopamine are like excitatory neurotransmitters. GABA, which is gamma aminobutyric acid, is an inhibitory neurotransmitter, and a balance should be maintained in order to maintain a standard threshold. But when this balance is disturbed, we get neuropsychiatric conditions. So let's talk more about the individual hallucinations of the senses. So hallucinatory voices were first called phonemes by Wernicke in 1900. Auditory hallucinations may be abusive, neutral, or even helpful in tone. And sometimes patients who have been abused may have really threatening hallucinations, but sometimes these auditory hallucinations could be helpful as well. And they could actually help them to get out of the situation they're feeling. A lot of times these patients use these helpful hallucinations to guide them to their episodes of psychosis. For others, the persistence of the hallucinations cuts across all activities, so the patient is listening and even replying to them at times. When I had met a child who was suffering from some sort of hallucinations, he would sit down in one corner of the room and talk to himself all the time. And this is what we call as responding to internal stimuli. At other times, disturbances in thought processes could lead to something known as thought echo or thought sonorization. Sometimes people also claim that the voices come from within their bodies, such as their arms, legs, or stomach. And other interesting thing is that patients who are not able to, how do I put this? They're not able to talk properly. Sometimes they say that they can feel a voice talking from within their throat and within their tongue. And when when they were measured, when the action potential of the tongue was measured, they found that the tongue at rest also produces action potential and generates stimulus. So it's surprising that a lot of patients still don't they don't say that they develop hallucinations from their throat as well. The next thing I'd like to talk about is vision, and a little more emphasis on vision. All varieties of visual hallucination are found in acute organic states, but small animals and insects are most often hallucinated in delirium. One patient in delirium tremens described mice carrying suitcases on their backs as they boarded a flight to Luz. Now, in a few minutes, I would talk more about delirium tremens, and it's a very interesting condition because it's not only related to dopamine imbalance or alcohol withdrawal, but also to disruptions of REM sleep. A lot of patients in delirium tremens also experience something known as Lilliputian hallucinations, which is very similar to macropsia and micropsia that is seen in Alice in Wonderland syndrome. So I'd like to go a step back and talk about something known as the theory of the bicameral mind. So this painting, as you can see, is a painting of Michelangelo's God and Man. And there's something very interesting about this painting. If you look at this painting and you look around God and look at the figure that is surrounding God, what does it look like? Well, there's been a lot of debates about this, but a lot of people do say that it does look like the human brain. If you look and see, you could see the cerebrum, you could see the brainstalk, you could see the optic chiasm, and you could see the medulla as well. Why would Michelangelo paint something like this? Well, the theory says that in the past, we had something known as a bicameral mind or a split brain, where we would hear a voice tell us to do something. For example, it would tell you to go and hunt or go and kill this animal. And the man would go and kill the animal. As we evolved, as consciousness evolved inwards, both the split came together and became one. And we have our own perceptions of ourselves, our own ego, and our psyche. So a lot of people say that this is the voice of God. And that's very popular among religious circles. But what happens in like psychotic illnesses is that very popular theory is regression. We do go back to our previous states. And a lot of times people hear these auditory voices, and this could be going back to states of the bicameral mind where people hear these voices. So now let's talk about the cases that I've seen. I'm going to talk about two cases. The first one was, I saw this patient yesterday, and this is the reason why I wanted to talk about hallucinations today. The patient was an 89-year-old right-handed female who came to the clinic complaining of hallucinations. She also complained of marked sleep disturbance and a disturbed circadian rhythm. Examples of her hallucinations included a procession of Chinese people in the room, cobwebs and spiders in the house. Now, mind you, this patient had no history of any psychotic illness. However, what she did have was a history of cataract surgery in the right eye and progressive bilateral loss of vision. The patient also had preserved insight into her hallucinations, where she knew that her hallucinations weren't real, but it was very scary and frightening to her. The only history that she had and the only medication she was receiving was medication for hypertension and type 2 diabetes mellitus. So immediately when I saw this patient, the first thing that came to my mind was Charles Bonnet syndrome. And the first time I came across this syndrome was while reading the book Hallucinations by Oliver Sacks. And as I mentioned before, Charles Bonnet syndrome is a manifestation and usually seen in patients with visual system abnormalities. And SPECT scans of these patients will usually show excitatory activity in the visual pathway and even in certain parts of the temporal lobe. To these patients, hallucinations seem very frightening. Sometimes they even might not be bothered by these hallucinations. They might actually enjoy them or even look forward to them. But to patients, when they are old and when they see this, they might think that they're going crazy, although they do have preserved insight. Differential diagnosis of visual hallucinations can be, well, the first options is neuroophthalmic diseases such as Charles Bonnet syndrome. Another type of hallucinations are physiological hallucinations, such as hypnagogic and hypnopompic hallucinations. Hypnagogic hallucinations are those that happen when the patient goes and falls asleep, whereas hypnopompic hallucinations happen when the patient wakes up. This is usually seen in states such as sleep paralysis, and is more commonly associated with people who are sleep deprived, excessive caffeine consumption, a lack of a deep sleep, and narcolepsy. Now, organic disorders which could lead to visual hallucinations include vascular dementia, Alzheimer's, Parkinson's, Lewy body disease, frontotemporal dementia, and Lermite's hallucinosis. Whenever the pathways in the pyramidal neurons, in the sensory neurons, and the motor neurons are disrupted, it will definitely lead to a change in perception. A lot of times, one of the first symptoms that patients with even brain tumors might have could be hallucinations, change in personality, and psychosis. Now, hallucinations are also very common in schizophrenia, psychosis, and states of delirium. And as I've stated before, also migraine, epilepsy, and narcolepsy. Other causes could include brain tumors, toxic states such as infectious organic insufficiencies, or drugs such as levodopa, brimonidine, opiates, alcohol, and other drugs of abuse. While there is currently no single treatment that is effective for all cases of Charles Bonnet syndrome, there are steps that patients can take that might have a positive effect. For example, optimal eye care and regular visits to the ophthalmologist, low vision aids to help maximize any vision, avoidance of conditions known to aggravate CBS, such as stress, anxiety, social isolation, and sensory deprivation. Now, what happens to a lot of patients when they lose their sense of vision is their sense of circadian rhythm gets disrupted. Now, what does that mean exactly? They're not able, the light is not able to hit their retina, and melatonin, the formation of melatonin gets affected. As a result, patients usually have a very disordered sleeping pattern. They're awake at night, as was the case with this patient, and sometimes they are awake for like 2 to 3 days. And certainly, fatigue will definitely affect their perception of the surroundings and can lead to worsening of their hallucinations and condition. Some studies have also shown that antipsychotics are very helpful for Charles-Bonnet syndrome. And also other studies have stated that repetitive transcranial magnetic stimulation does help in certain cases of Charles-Bonnet syndrome. Now, the main emphasis I'd like to talk about is new studies have shown that hallucinations can occur as a result of imbalances of REM sleep. And sleep study was something which is very crucial in this current posting of neurology that I had at AMIQT. So I'd like to go a little bit of more detail into this. So there must be a connection with sleep. Now, the previous school of thought has said that imbalances in neurotransmitters could be responsible for hallucinations, but recent studies have also shown that sleep is very crucial for hallucination formation, and I'll tell you why. We have many phases of sleep and multiple phases of REM sleep when we sleep at night. Now, REM sleep is very important because, as you all know, random eye movement is the phase of sleep where our eyes randomly dot from one side to the other and we dream. Whenever I take a history of a patient, I always like to ask them, did you dream last night? Now, why do I ask them that? Well, most of the time it's said that if we don't remember our dreams, that means we have had good sleep. Now, what does that mean? In REM sleep, if you wake up during REM sleep, that is the phase that we are dreaming, it means that we have had a disturbed sleep. Whereas if you wake up during NREM sleep, we don't dream during that phase and we have a lot of difficulty to remember our dreams. So why am I talking about this? This is a very famous painting by Henry Fuseli. It's called The Nightmare. It's an accurate description of what happens in sleep paralysis, which is a form of hypnagogic hallucinations. So when the patient usually falls asleep, the body gets tricked into a state of atonia, where the patient has a very visual dream and feels very scared. Right. And the consciousness manifests that there's an intruder in the room or there's something scary happening. And this leads to a form of a hallucination, and most popularly known as a nightmare. The episodes usually last for about 5 to 10 minutes, and the patient usually wakes up sweating in agony and in a lot of fear. This is an example of an REM sleep behavior disorder and could be associated with patients suffering from Parkinson's. A lot of studies have said this, and it's very common in patients suffering from typical as well as atypical narcolepsy. Now, case 2. The patient was a 43-year-old male who developed hallucinations and tremors after an episode of binge drinking for 72 hours and disturbances in sleep. He's also known as a patient of a major depressive disorder, and his medication history is not known. So in chronic alcoholics, what happens is that they drink a lot, and alcohol and other drugs disrupt REM sleep. Now, according to Matthew Walker, in his book, Why We Sleep, he stated that in his studies that the body likes to have a certain amount of REM sleep. And if the body does not get that REM sleep, the body is going to want to balance it. And the way that it balances it, well, if it's not going to get REM sleep when you're sleeping, there's only another state of consciousness where it's going to get REM sleep, and that is the awake state. And that is what happens to people with delirium tremens. They have so much disturbances in REM that they're not able to dream when they sleep. So the body compensates by making them dream in reality. And this manifests as hallucinations. And a very popular hallucination in alcoholic patients are Lilliputian hallucinations, where they see multiple small men running around their body or running around the environment. And a lot of times you will find these patients looking at these hallucinations and laughing as they find it very pleasurable. So how do we treat patients with alcohol withdrawal? Well, First, we have to look at for the signs of Wernicke's encephalopathy, because alcoholic patients usually have thiamine deficiency, which could lead to memory loss and body atrophy. So we have to look for all the signs. We do all the basic investigations, laboratory investigations. And what we do next is usually we treat them with a drug that would give them the same amount of, like they used to self-medicate their sleep issues with alcohol. So diazepam has a similar mechanism of action. Other drugs that could be used for there are other drugs which are used for refractory states, and these are stronger drugs, and even antipsychotics could be used as well. So what would I like to conclude about hallucinations? Can the study of dreams contribute to our understanding of the genesis of hallucinations and or delusions? And I would like to say that yes, dreams can do that, because as I said, if we do not dream when we are sleeping, our body would like to compensate by dreaming when we are awake. And this could be another interesting mechanism for patients to experience hallucinations or delusions. And it's not only going to be because of an imbalance in neurotransmitters. And however, I'd like to let you know that sleep also, during NREM stages of sleep, it is a time when the body fixes itself, the body fixes its mind. It's the period of sleep where consolidation of memory takes place from short-term to long-term, and the healing of the body takes place, as well as the regrowth of neurotransmitters. The second thing I'd like to conclude is, are the mechanisms underlying the hallucinations and or delusions in schizophrenia the same as those responsible for the hallucinations and delusions caused by psychotropic drugs? Well, studies have shown, especially in SPECT scans, a lot of similarities between patients who are suffering from psychotic illnesses such as schizophrenia and other people who are ingesting psychedelic substances. The similarities are very similar. And also, you can say that people who take such psychotropic substances experience a state of mania, and they're not able to have a stable state of mind. They have like an acute bipolar episode, very similar to the mania seen in bipolar 1 disorder, and they also have disturbances in perception. Do differences in the absence and or presence of disturbed consciousness, including sleep, explain the psychotic features? Patients who are manic, they do not sleep for many days, and this would lead to a disruption in REM sleep, manifesting as dreaming in reality, and could lead to the development of hallucinations as well. Is there any difference between the hallucinations and or delusions caused by organic brain disorders and those seen in schizophrenia? Well, this is quite controversial, but schizophrenia has many types. There's type 1 and type 2 schizophrenia, and schizophrenia also could be organic as well. It has been associated with brain shrinkage, such as a lot of patients who have consumed marijuana do experience something known as brain shrinkage. And this is an organic disorder which manifests and gives them a higher risk of developing schizophrenia in their lifetime. A lot of patients who have brain tumors or have any other sorts of organic disorders also develop hallucinations, which are very similar to patients seen in schizophrenia. And these are the references to my presentation. I have taken a lot of information from Fisher's Clinical Psychopathology, as well as Wikipedia and the National Institute of Health. Thank you. I would like to conclude my presentation saying that although we know that neurotransmitters are the primary disturbances which lead to hallucinations and other psychiatric disturbances, disorders of sleep could lead to manifestations in the wakeful state and also manifest as hallucinations and contribute to the worsening of psychotic symptoms as well. Thank you.
Thank you very much.
Thank you, sir.